Hello again. We're going to continue our discussions of the cardiovascular system, and today we're going to focus on blood flow, blood pressure, and regulation and control. And so if you remember, we've talked about blood, we've talked about blood vessels, we've talked about the heart. And so the heart is pushing blood through the blood vessels. And so we can call this blood flow. And so blood flow is the volume of blood that's flowing through a vessel, an organ, or the entire circulation at any given period. And we typically measure that as milliliters per minute. It's typically pretty constant at rest, but it can change. You can move blood from one area of the body to another, shunt it, and so you can increase blood flow to areas that maybe need more blood at a certain point in time. So let's think about, so for example, if you're very, very hot and so you start to flush, well, what you're seeing is that blood being shunted from the core to the skin to give away heat. So you can change the blood flow to your skin by opening up capillary beds and allowing more blood to flow to your skin. If you're very, very cold, you may notice your skin is pale, and that's you shunting that blood, changing the blood flow from the skin back to the core to keep your heart warm and your internal organs. And so they will measure blood flow. So for example, if you have some sort of blockage, they may want to measure the blood flow that's going out to an arm or a leg or an organ to make sure it's getting proper blood flow. And so why is it important that blood's flowing through a tissue? Well, we call this tissue perfusion, and it's very important because that's the way we get oxygen, and particularly oxygen and also nutrients to those organs and to those tissues. So when a tissue is being perfused, when blood is flowing through it, then oxygen and nutrients are being carried to that tissue. In addition, not only are you taking things to the tissues, you're removing any waste products, okay, like CO2, like carbon dioxide. And so all of our organs need to be perfused. Without perfusion, you're going to get ischemia and then possibly necrosis, which is the tissue will be dying off. That's really what happens in frostbite. You start to the fingers become so cold and there's no perfusion anymore, there's no heat, and the tissue starts to die. So you want to perfuse your organs. And so some examples of organs that perfuse and that are very important are the lungs. And so when you perfuse the lungs, the purpose of doing that is gas exchange, to bring oxygen into the blood and then to remove CO2 from the blood. You also want to have perfusion in the small intestine and the digestive tract. So if you remember, the small intestine, as food is traveling through the small intestine, nutrients are going to be broken down and then absorbed into the bloodstream. So you need a really good blood flow to the small intestine in order to absorb nutrients from it. You also need blood flow to the kidneys. And so as blood is flowing through the kidneys filter that and they form urine. So we're going to do units that are on the lungs, digestive tract, and kidneys in this course, and so you're really going to see the importance of blood flow in those organs as we move through those individual systems. So again, we can change blood flow. We can regulate it precisely in order for the organ to have exactly the amount of blood it needs to provide and do its function. Okay, so if we need to have more oxygen and carbon dioxide moving through our lungs, we can change our breathing rate, but we can also change the amount of blood that's going into our lungs. Okay, and we do this using what are called precapillary sphincters. And so you should have already seen this when we talked about the anatomy of the blood vessels. But if you remember, you have arteries that go to arterioles and then into capillaries, right? And then those capillaries become venules. Well, let's draw a couple of vessels here. So let's say blood flow is going in this direction, all right? And so it can go this way and it can go this way, all right? So if we are trying to get blood to our skin, we may open up the precapillary sphincters to this capillary bed and allow more blood to flow into the capillary beds of the skin, getting that flushing feeling, all right? If we do not need blood there, we'll close those capillaries and the blood will simply flow into the next down the next vessel. All right, so we can change the way blood flows into capillary beds by opening and closing precapillary sphincters. You should have seen that earlier in anatomy. If not, go back, look at your textbook, look at your figure, and you will see these precapillary sphincters and remind yourself of what their job is. Now, as blood is flowing, it's creating a pressure. So blood pressure is the pressure of the blood on the wall of the blood vessel. So you imagine a blood vessel as a tube. As the blood's flowing through it, it is that pressure it exerts against the wall. And we use the term systolic over diastolic to measure blood pressure, and we measure it in millimeters of mercury. And it's a principal vital sign. So if you go to the physician, to go to the doctor, go to the nurse practitioner, go to the ER, they're usually going to take your weight, and they're going to take your blood pressure and your temperature. I've never been to the doctor where those three things weren't done. So blood pressure can be an indication of your overall health. And the blood pressure is the driving force that's moving the blood through the tissues, allowing them to be perfused, and it's going to go from high to low pressure areas. Now, when I use the term blood pressure, and I'm talking about blood pressure that we're especially measuring as one of those principal vital signs, I'm talking about arterial blood pressure. Okay, so we're talking about the blood pressure in the arteries near the heart. So if you think about a person, okay, you guys know I can draw, right? So here's your heart. Well, the highest, the most accurate blood pressure would be the blood pressure in the aorta, but you really can't put a blood pressure cuff around the aorta. And so think about where the blood's going to go next. So you've got your carotid and your brachiocephalix, your subclavian, your axillary and brachial. So which artery you could easily measure by using a blood pressure cuff? Well, you don't want to do it around the neck. You'd pass out. So the brachial artery is probably the most easily accessed place to measure blood pressure. That's why you have a blood pressure cuff. When you go to the doctor, they take it on the arm, because that's the largest, really most accessible artery that you have to measure the blood pressure. So when they take the blood pressure cuff and they squeeze it and they release the little dial and you can feel it squeezing on your arm, what they're measuring is what's called systolic pressure over diastolic pressure. And we actually do this in lab, and we'll go over in another video how you take blood pressure and what you're listening for and how you do that. So the systolic pressure is the high pressure. It's the maximum pressure that's given or exerted during ventricular contraction or systole. Remember, contraction and systole are the same in the ventricles. So when the ventricles contract, forcing that blood to the aorta, that's your systolic pressure. And that range is anywhere between 90 and 140 millimeters of mercury. The diastolic pressure is the minimum, so it's the low pressure when the ventricles are relaxed or in diastole. And so that would be 60 to 90 millimeters of mercury. And so systolic pressure, when you see someone with a blood pressure, it's usually going to be written something like that. The systolic pressure over the diastolic pressure. The high number over the low number. The contraction number over the relaxation number. All right. The pulse pressure is the difference between the two. Okay, and that's what you're feeling is when you feel a pulse. You can also do mean arterial pressures, and this is when you're just taking the average of the systolic and diastolic pressure as you're measuring that through the entire body. So I have a chart here to demonstrate that. So what you see is a systolic, the upper line, and a diastolic, the lower line, and then the mean, the difference, the mean between those two right here. All right, and so you can measure that mean arterial pressure as it's traveling through the body. What I hope you notice right away is that the difference between the systolic and diastolic goes away pretty quickly. By the time you're in the arterioles and capillaries, there's not a big difference between the systolic pressure and the diastolic pressure. And so you've just got what you're feeling is your pulse as you get down to those smaller and smaller arteries. Not a whole lot of difference there. I also want you to recognize, so this is the aorta, and so these are the large arteries. So think carotids, brachial arteries, things like that. You'll notice that in these large arteries, the systolic and diastolic numbers have not changed a whole lot. So taking the blood pressure at the brachial artery is pretty accurate of telling you what's going on at the aorta. So it's a pretty accurate number. All right? So that's why we measured in those large arteries, specifically the brachial artery, because it's close to the heart. Now you'll notice that systolic pressure and diastolic pressure start to fall as the arteries become smaller and smaller arterioles, till finally at the capillary beds it's around 20 millimeters of mercury, and it continues to fall to almost zero when you get to the vena cava. So if you think back to perfusion, we talked about how things are exchanged at the capillary bed. Hopefully you remember that. We talked about how when things go to a capillary, you have two pressures that are causing and driving the driving force to allow things to be delivered out into the tissues. Do you remember the hydrostatic pressure and the osmotic pressure. So which one was driving things out of the capillary bed? That was the hydrostatic pressure. And that's essentially this pressure here that's still being exerted by the blood pressure in the capillary bed. So remember, if you're pushing things out, you got to bring that fluid back, and that's that osmotic pressure that's being exerted by the big plasma proteins in the blood. So you do have a little bit of pressure in the capillaries forcing things out into the tissue so that you can have exchange. So again, that pressure is going to decrease, decrease, decrease till it gets all the way to about 0. So if there's no pressure, very little pressure, decreasing pressure in the venules, the veins, and the vena cava, how is that blood returning to the heart? I mean, this makes sense. We're pushing it. We're pushing it through the arteries. How does it come back the other way? So you have those pumps. Remember the respiratory pump and the muscular pump? If you don't, go back and look at it. So we're returning the blood to our heart using valves and the muscular pump and the respiratory pump, okay? Because we don't have blood pressure to push that blood back. All right, so blood pressure is not static. Okay, it does change throughout the day, and it can cycle over a 24-hour period, which is why if you have blood pressure issues, your physician's most likely going to have you take your blood pressure throughout the day so they can monitor how it's changing. What's the highest blood pressure that you have? What's the lowest blood pressure you have? So it gives them a really good idea of what they need to treat, because maybe every time you come in you have high blood pressure. Well, there is something called white coat hypertension where you get nervous, and so that sympathetic nervous system kind of causes your blood pressure to go up. So every time you go to the doctor, your blood pressure's up. Well, it turns out at home it's just fine. So they may send you home with a blood pressure monitor to make sure that you don't have white coat hypertension. Let's see what your blood pressure actually does when you're not stressed out. Typically, the blood pressure is going to be lowest while you're asleep. It's going to start to raise or go up a few hours before you wake up due to hormones. It's kind of one of the things that helps wake you up as your blood pressure is starting to rise and wake you up. It'll continue to rise throughout the morning, so blood pressures mid-morning can be some of your highest. Mid-morning to midday can be some of your highest pressures. And then they start to go back down as you get into late evening. Okay, so it kind of follows your sleep-wake patterns. It does vary based on age and sex and weight and race. Okay, so if you have high blood pressure, it may be could be hereditary, and it also may be some variables that you can't control, like how old you are, what your sex is, how much you weigh, and what your race is. It can also change just by moving. So changes in posture, physical exertion. If you're upset, if you have fever, remember that sympathetic nervous system? You're nervous, so your blood pressure will go up. If you're if you've got a fever, your blood pressure can go up. Some people have what's called orthostatic hypotension. So have you ever been laying down and you sit up and all of a sudden you feel lightheaded because your blood pressure kind of bottoms out? If you have blood pressure issues, they may actually measure your blood pressure laying down and sitting up just to see what the difference is. Normal blood pressure is about 120/80, so that's kind of the standard normal blood pressure. You're considered hypertensive if your blood pressure is anything above 140/90. Now, in the old days, they used to really look at that systolic pressure, and that was kind of the big number. But now they're really focusing on the diastolic pressure. So used to, you could have 140/100. They were really, really worried about how high the top number is. But now they're more concerned about how high the low number is. Because if that low number is high, that makes sense? If it's 90 or 100, if your diastolic pressure is high, that means there's a constant force pushing against those blood vessels, and that's what you want to avoid because that's going to cause damage. So when they look at hypertension, they really have shifted their focus from the systolic pressure to the diastolic pressure. So if you have a hypertension, they're going to treat that because it starts to do damage to organs like the heart and the kidney, and we'll talk more about that later. Hypotension is if your systolic pressure is below 100, and that's usually not going to be a problem. Low blood pressure, unless you're having syncope or periods of fainting or passing out, low blood pressure is generally considered healthy. So don't be worried if you have low blood pressure. Unless you just feel bad and fatigued, then maybe there's an issue. So how do we maintain our blood pressure? It requires three things: the heart, the blood vessels, and the kidneys. And when we talk about the heart, we're talking about cardiac output. And so you should have already learned about cardiac output and how you can regulate cardiac output by changing heart rate and stroke volume. Okay? The blood vessels, their role is by changing what's called peripheral resistance, and we're going to talk about that in just a minute. And also the kidneys. The kidneys regulate the amount of blood volume you have, and they do that by increasing and decreasing urine formation. Okay, so you can regulate how much volume's in your blood by increasing or decreasing how much urine you form. And we'll talk about more detail in that later on as well. All of these are going to be supervised by the brain, so it's in ultimate control. So what is peripheral resistance? So resistance is opposition. So this is opposition to flow. So think about it as friction, so how much friction the blood encounters. And this occurs in the peripheral systemic circulation. So kind of as the arteries get smaller and smaller and smaller, the more peripheral they are, this is where they're going to encounter the most resistance. There's three ways to increase or change resistance. One is called viscosity. And you can think of that as how sticky the blood is. And so the more blood cells that you have, the more plasma proteins, the thicker it is, the more sticky. Okay. You can change resistance by the length of the vessel. The longer the vessel, the more resistance. The vessel diameter, how big around it is, how on the inside. The smaller the vessel, the greater the resistance. Okay. But can we or do we change these? Well, blood vessel length and blood viscosity really don't change all that much, okay? So the stickiness of the blood doesn't really change. The more sticky it is, the more viscosity, the more resistance you're going to have. But you don't see that unless you're severely dehydrated, so that kind of thickens up the blood, or if someone has taken erythropoietin, blood doping, and has an increased number of blood cells in their blood. So you typically don't see this widespread changes in viscosity. Blood vessel length. Well, you don't really sprout an extra blood vessel overnight. So once you kind of reach your full size, your blood vessels pretty much stay the same. Okay. You may see changes. You do increase your amounts of auxiliary or extra capillary beds as you put on weight. You will actually grow some new vessels. So in that case, you may see increased vessel length. But vessel length doesn't really change day to day. Okay? What does change is diameter. And so that's what has the greatest influence on peripheral resistance. Blood vessels can expand and contract, or vasodilate and vasoconstrict. So vasoconstrict means get smaller, vasodilate means get bigger. And these changes in the diameter of the vessel are the greatest changes in resistance. So if you narrow a vessel, you're going to increase the resistance. If you dilate the vessel, you're going to increase or decrease the resistance. I think I said that right. Increase the resistance when it vasoconstricts, decrease the resistance when it vasodilates. All right. So again, any of these small diameter changes in these arterioles are going to really change your peripheral resistance. And so here's one of those slides I was talking about with those sphincters. All right. So you've got smooth, here are those precapillary sphincters I was talking about that allow you to shunt blood through capillaries. But here are the smooth muscle walls that are around the small arterioles. And so they can actually contract and relax. And when they contract, they decrease the size of the inside of the vessel. And so if you increase or decrease the size, so here's an arteriole, vasodilated, and here's the same one vasoconstricted, so that the inside of the vessel is smaller. Which one's going to have the higher pressure, the most resistance? The bigger one or the smaller one? So let's say it's got an equal amount of volume in there. So you've got a tube with water in it, and it's flowing through. Now you squeeze and make that vessel smaller. What happens? The pressure goes up, right? You increase the resistance, you increase the pressure. You also see this in people with atherosclerosis, which is going to be plaques inside the vessels. The more plaques you have, all right, so you're actually decreasing the size of the vessel because you've got plaque buildup. That's going to increase resistance. Okay, so it can actually cause turbulent flow, and so you can get clots. So this can be a factor in heart attack and things like that. So people with atherosclerosis are at risk for heart attack because of the turbulent flow and the risk of clots, and also for high blood pressure. All right, so before we put all this together, let's make sure we remember cardiac output and what can change cardiac output. If we want to increase cardiac output, what can we do? What are some things that increase cardiac output? We can exercise. Remember, exercise. That will increase the activity of the respiratory pump. It will increase the activity of the muscular pump. We'll have sympathetic, because you're exercising is stress, so sympathetic nervous system is going to kick in, cause vasoconstriction, going to decrease the size of the vessels, increase pressure. That's going to increase venous return, increase end diastolic volume, increase stroke volume, increase cardiac output. All right, so that's one way. So if you're increasing cardiac output, that can increase blood pressure, okay? If you have a decrease in blood pressure, how can that affect cardiac output? Again, this is just review, because when I talk about cardiac output, I want you to realize how cardiac output and blood pressure are related. So if blood pressure's decreasing, what can happen? Well, your sympathetic nervous system can kick in to try to increase it. Your parasympathetic nervous system will kind of shut down to let your sympathetic nervous system take over. So the sympathetic nervous system is going to cause the release of epinephrine. Epinephrine, like adrenaline, is going to cause your muscles to become more contractile. The strength is going to be harder, stronger. That's going to decrease your end systolic volume. That's going to increase your stroke volume. It's going to increase cardiac output. All of these also increase heart rate. So remember, you can change cardiac output by changing stroke volume and heart rate. All right, so bringing that back, what does that have to do with blood pressure? Well, blood pressure varies directly with your cardiac output, your peripheral resistance, and your blood volume. So anything that changes cardiac output, anything that changes peripheral resistance, anything that changes blood volume can change blood pressure, okay? And so if your cardiac output is changing, your peripheral resistance may compensate for that. If your blood pressure is changing, your cardiac output may compensate for that to try to maintain and keep blood pressure constant. So let's give a couple of examples. Let's say our blood volume is increasing, all right? So we have had a lot of fluids. It's a lot of fluid that's going into our blood. Sorry about that. I know that sounded great. Apologize. And I cannot edit that out, so sorry. All right, so as blood volume is increasing, that's going to increase blood pressure, okay? As peripheral resistance increases, make sure it's still on, it's going to increase blood pressure. As blood viscosity increases, so as viscosity increases, that increases peripheral resistance, that increases blood pressure. If you're increasing the amount of venous return, that's going to increase your stroke volume, that's going to increase your cardiac output, that's going to increase your blood pressure. What if you decrease the amount of venous return? Well, if venous return decreases, then stroke volume decreases, cardiac output decreases, blood pressure decreases, okay? If blood volume decreases, what happens to blood pressure? It decreases. So you see how these are directly related. And we're going to do this again when we talk about blood pressure, but right now just realize that all of these things are directly proportional, okay? So as any of these increase or decrease, they're going to change and affect blood pressure. All right, I think this video has gotten long enough, and I need to fix my mic for the next one. So we'll just move on, and I will see you in the next video. Thanks a lot.